Welcome, class, to today's lecture on gastric polyps. In this detailed script, we will explore the various aspects of gastric polyps, including their definition, classification, epidemiology, risk factors, clinical presentation, diagnostic approaches, management strategies, malignant potential, and complications. Additionally, we will delve into specific types of gastric polyps, such as adenomatous polyps, hyperplastic polyps, fundic gland polyps, and inflammatory polyps. We will also discuss polypectomy techniques, follow-up and surveillance, as well as the prognosis associated with these lesions. Without further ado, let us begin our exploration into the world of gastric polyps. Gastric polyps are non-cancerous growths that arise from the lining of the stomach. They can be small or large and are classified based on their appearance under the microscope. Understanding these classifications helps in diagnosis and treatment decisions. The epidemiology of gastric polyps depends on the type. Adenomatous polyps are common in older individuals and linked to chronic inflammation, H. pylori infection, and genetic factors. Hyperplastic polyps are more prevalent in younger people and associated with chronic gastritis and H. pylori infection. Fundic gland polyps occur in patients using long-term PPIs and may indicate certain syndromes. Inflammatory polyps are typically seen in conditions like Crohn's disease or infection. Understanding these factors is vital for managing gastric polyps. The clinical presentation of gastric polyps can vary greatly, ranging from being asymptomatic to causing significant gastrointestinal symptoms. Many gastric polyps are incidentally detected during endoscopic examinations performed for unrelated indications. Symptomatic gastric polyps may manifest with symptoms such as epigastric pain, nausea, vomiting, gastrointestinal bleeding, or even gastric outlet obstruction in rare cases. The presenting symptoms often depend on the size, location, and histological type of the polyp. It is important for clinicians to be aware of the clinical presentation of gastric polyps to appropriately evaluate and manage patients with suspected or diagnosed lesions. Accurate diagnosis of gastric polyps is crucial. Upper endoscopy allows direct visualization and biopsy. Imaging techniques aid in detection and characterization. Histological examination confirms diagnosis and guides management decisions. Endoscopic ultrasound assesses invasion depth. A multimodal approach is necessary for diagnosis. Gastric polyp management depends on size, histology, and patient characteristics. Small, low-risk polyps may be monitored. Larger or high-risk polyps may be removed using endoscopy, while surgery is an option for cases where endoscopy is not feasible or malignancy risk is high. Collaboration between specialists is crucial. Adenomatous gastric polyps, characterized by dysplastic epithelial changes, have the highest risk of turning into gastric cancer. Variables like polyp size, dysplasia degree, and risk factors affect this risk. Large polyps, high-grade dysplasia, or chronic gastritis necessitate monitoring or resection. Endoscopic or surgical approaches may be used based on invasiveness. Close monitoring is vital for early intervention. In summary, hyperplastic gastric polyps can potentially be malignant, especially if they have certain histological features or are associated with risk factors. Management involves surveillance and individualized decision-making, which may include endoscopic resection or surgery. Fundic gland polyps are often seen in patients on long-term proton pump inhibitors, PPIs. They are usually harmless and don't need treatment, but discontinuing PPIs may be advised. These polyps can also be linked to genetic syndromes like FAP, requiring additional monitoring and care. Understanding this association is important for appropriate management. Inflammatory gastric polyps are caused by chronic inflammation in the stomach. They can be associated with conditions like chronic gastritis, H. pylori infection, autoimmune diseases, or inflammatory bowel disease. Treating the underlying condition is key. Larger polyps or those with dysplasia may require endoscopic removal. In this video, we will discuss the different polypectomy techniques used for gastric polyps. Factors influencing the choice of technique include polyp size, location, and complexity, along with the endoscopist's expertise. Conventional polypectomy is suitable for small pedunculated polyps, while endoscopic mucosal resection, EMR, is used for larger or sessile lesions. For larger and more complex polyps, endoscopic submucosal dissection, ESD, allows for precise dissection and decreased risk of perforation. Understanding these techniques is essential for successful outcomes and avoiding complications. After diagnosing gastric polyps, regular follow-up and surveillance are crucial to monitor for recurrence, potential cancer development, and adjust treatment plans. The follow-up interval depends on factors like polyp type, dysplasia presence, and initial resection quality. Simple hyperplastic polyps may require less frequent follow-up, while larger or higher risk adenomatous polyps may need more frequent surveillance. Surveillance often involves repeat endoscopy with biopsy to visually assess the polyp site, check for healing or recurrence, and examine any new or concerning lesions. A systematic and personalized approach to follow-up and surveillance is vital in promptly detecting and managing any recurrent or new polyps. Gastric polyps can cause complications including pain, obstruction, and bleeding. Malignancy is a concern, especially in adenomatous polyps. Prognosis depends on histological type and management. Benign polyps are usually manageable with surveillance, while adenomatous polyps require close monitoring and intervention. In conclusion, gastric polyps are common benign lesions in the stomach. Accurate diagnosis, individualized management, and regular follow-up are essential. Different types of polyps have different implications and treatment approaches. Future gastroenterologists should stay informed to provide the best care.